Fantastic audience joining us. Am I audible, sir?
Yes, yes.
Myself, Dr. Jaykumar Ade, and working as assistant professor at SGR Ayurveda College, Solapur. Our aim through this Ayurveda Besanam National Online Kriya Sharir lecture series is to create a platform for knowledge sharing and meaningful discussion. I request Divyani Mahajan, second year BA student, SGR Ayurveda College, Solapur, for Lord Dhanvantari Stravan. Divyani Mahajan.
Yes, sir. नमामि धन्वन्तरिमादिदेवं सुरासुरे वन्दितपादपद्मं लोके जरार भयमृत्युनाशं दातारमीशं विविधौषधीना शङ्खं चक्रं जलोका ददतमृतघटं चारुदुर्भिश्चतुर्भिः सूक्ष्मस्वच्छातिरुद्यां शुकपरिविलसन् मौलिमम्भोजनेत्रं कालाम्भोदोज्ज्वलाङ्गम् कटितटविलसच्चारुपीताम्बराढ्यं वन्दे धन्वन्तरिं तं निखिलगदवन प्रौढिदावाग्निनीलम्
थैंक यू दिव्यानी। आज के इस नेशनल लेवल लेक्चर सीरीज में केंद्र तथा प्रांत की ओर से हमारे बीच अधिकारी मौजूद है। केंद्र की ओर से डॉक्टर मुरली कृष्ण सर और प्रांत के अधिकारी के तौर पर वैद्य संतोष जी गटने सर मौजूद है। डॉक्टर कृष्ण मुरली कृष्णन सर प्रचारक रहे। वो 1980
करंट लगता है।
मैं संक्षिप्त में डॉक्टर मुरली कृष्ण सर का संक्षिप्त में उनका परिचय करके देता हूँ। डॉक्टर मुरली कृष्ण प्रचारक since 1982 from Andhra Pradesh after completing the MS, work as a Prant Seva Pramukh for 12 years. 20 onwards in Arogya Bharati. 4 years joined as a Dakshin Madhya Kshetra Samchak. 2015 to 2024 work as a Rashtriya Sanyojak. As a राष्ट्रीय सह संगठन सचिव केंद्र चेन्नई तमिलनाडु। तो आई रिक्वेस्ट डॉक्टर मुरली कृष्ण सर काइंडली गाइड अस। ओवर टू यू सर।
Good evening to everybody, our respected elders and beloved students. Firstly, I want to congratulate the team of Arogya Bharati, Paschim Maharashtra. The effort is very appreciable to strengthen the academic base of Ayurvedic students and practitioners. अभ्यास वर्ग ऐसा नाम रखा है, it's very nice, and we know the practitioners of Ayurveda should begin with this end. Even though we know the modern and allopathy observations, you must know definitely it is advisable also, but we should not leave the basic dosha chikitsa. So you must have the knowledge of the Pratyaksha Pramana, Anumana Pramana, and Aptopadesham. This will help us a lot. When you begin with the Dosha Chikitsa, then all things will be set right. And Desha, Kala, Pariksha, and Rogi Balam, Roga Balam, all these things are basics for Ayurvedic treatment. We all know. Really, I am odd man. I left practicing 40 years ago, but I am working in the Seva aspects and Arogya Bharati. Once again, I appreciate and congratulate the team of Arogya Bharati. I don't want to waste the time of students and co-doctors. Thank you very much to giving chance to participate with you. Thank you. Namaste. Namaste.
Thank you, sir. It's immense pleasure having you, sir. Your remarkable contribution in our organization always inspire us. दूसरे प्रांत अधिकारी के तौर पर वैद्य संतोष जी गटने भी हमारे साथ है। मैं उनका संक्षेप में परिचय करा के देता हूँ। संतोष जी गटने सर सचिव हैं आरोग्य भारती पश्चिम महाराष्ट्र प्रांत के। साथ में वो महाराष्ट्र आरोग्य विज्ञान विद्यापीठ नासिक के सीनेट सदस्य तथा स्थायी समिति सदस्य भी है। आयुर्वेद चिकित्सक एवं आयुर्वेद औषध निर्माता पुणे। सर आपका भी बहुत बहुत स्वागत है। Today's webinar is on clinical examination of respiratory system. This is very important topic to all undergraduate as well as postgraduate students. The respiratory system is central to human life and its diseases are among the most common we encounter. For students, clinical examination skill not only sharpens the clinical judgment but also strengthens the doctor-patient bonds. By the end of this session, we hope participants will gain deeper insight into the clinical examination of respiratory system. It's my privilege to introduce our esteemed speaker for today, Dr. Raviraj Pardeshi sir. Raviraj Pardeshi sir is working as a professor at Sri Govindrao Wanjari Ayurveda College, Nagpur. With his vast experience in academic, he has contributed immensely through the research wing also. We are indeed honored to have him with us today. The flow of today's session will be, firstly, we all have presentation by our resource person, followed by a short question and answer session. I encourage all participants to drop your question in the chat box. We will take them up at the end. A gentle reminder to kindly keep your microphone on mute during the session to avoid background disturbances. Please use chat option for question and we will ensure they all will addressed. So without taking much time, let's begin. It's my honor to invite Dr. Pardeshi sir to take over the session and enlighten us with his knowledge. Over to you, sir. Dr. Pardeshi sir, please.
Thank you, Dr. Jay. And thank you, Arogya Bharati, Paschim Maharashtra Prant, for giving me this opportunity to share my knowledge and experience with student and faculty as well. So let me share my PowerPoint presentation. I hope it is visible. Please confirm once.
Yes, sir.
Yes. So the title given to me for today's session is Clinical Examination of Respiratory System. I request everybody to be on mute, please. Please ensure that everybody is muted. Thank you. So for this particular session, I have limited my talk, or I'll be limiting my talk to modern system of examination. And if we at all want Ayurveda to be included, then we will have to have another session where we will be comparing how the Ayurvedic parameters can be looked from a modern perspective also. So if students want and if faculty desires, then we will have another session where we will deal respiratory system from Ayurvedic perspective. So these are the course outcome which can be met after going through this session. So I'll not read this. These are program outcomes. So I'll directly come on to the learning outcomes. So at the end of this session on clinical examination of respiratory system, students should be able to elicit a focused history and perform a systemic physical examination of the respiratory system, including inspection, palpation, percussion, and auscultation. So keep every term of this in mind, and we will be going through each of these terms during our presentation. Next is identify, interpret, and accurately describe common clinical signs observed during respiratory examinations and correlate findings with potential underlying diseases. And third is demonstrate correct technique and communicate findings effectively in both simulated and real patient scenarios, ensuring a comprehensive and ethical clinical evaluation. So these are the learning outcomes for today's session. So what physiological function the respiratory system has to perform? So you all know that this is the system which is exposed to the atmosphere at all times. Right from birth up to death, we are exposed to the atmosphere. We keep on inhaling the air from the atmosphere. So there is a direct one-to-one connection with the world, we can say, or with the atmosphere where we are living. We inhale the air which may be full of dust, may have certain organisms mixed in it, and so on. So this is one. Second, it breathes. The air comes in and air goes out. So while coming in, it brings oxygen, and while going out, it goes with CO2, which is to be expelled or which is exhaled out in the atmosphere. So there is a kind of a gas exchange. So these lungs do not take for themselves. The oxygen comes inside so as to allow the tissue to get their energy, required energy, because this oxygen combines with the substrate, mostly carbohydrate, which is present in the food, and energy is produced, and this energy is utilized for overall metabolic activity of cells, tissues, and organs. Another function of respiratory system is to produce sound. The exhaling air, when it comes through vocal cord, it produces certain kind of a vibrations which results in production of sound. The respiration, the nose in particular, helps us to perceive smell also. Apart from this, the structure of the respiratory system is such that it filters, it provides moisture, and it provides warmth. It resists temperature of incoming air, because this is required so as to ensure that the air which is reaching to the lungs or going into the alveoli is free from the physical impurities. So these are the functions. So if the respiratory system is disturbed or the function is not proper, then a person may fall victim to the illness. So if we want to examine the respiratory system, so there are 4 key steps. The first is inspection. Observe the chest and respiratory pattern, because there are some of the signs which can be visibly clear and which can help the physician to sense that the patient is in distress or is having significant abnormality. Second comes palpitation, where a physician feels the chest to assess movements, to see whether tenderness is there or to see whether there are any kind of subcutaneous abnormality. Third is a percussion, where the physician taps on the chest to evaluate underlying tissue density. Fourth is auscultation, where there is an active listening to the breath sounds with a stethoscope to detect abnormal respiratory sounds. And nowadays we can use some of the monitoring tools which have become essential part of pulmonary examination or respiratory, that is pulse oximetry and capnography. So the lecture is having focus on lower respiratory tract, but I should touch to some of the aspect of upper respiratory tract also, where the nose, tonsils, pharynx, epiglottis, and these structures are involved. So a physician must look first into whether there is any obvious abnormality in this structure which are part of a upper respiratory tract infection, whether there is a discharge, whether there is a redness, inflammation, swelling, some kind of exudate or lymph node enlargement, because that also comprises examination of a respiratory tract. Before proceeding with the physical examination of the respiratory system, it is essential to gather a comprehensive clinical history and perform general assessment, because history gives us a hint to so as to decide which particular part we should focus on. So to begin with, we should ask the patient whether he or she has a particular symptoms, and first and the foremost and the most common symptom which is of the respiratory pathology is cough. So whether the patient is having cough at all, whether it is dry in nature, or whether patient expels some sputum, which we call as a productive cough, for how many days or months the patient has had cough, whether there is any blood in the sputum, which we call as a hemoptysis, whether patient feels breathless, we call this as a dyspnea, where this dyspnea is severe, what are the triggering factors, is dyspnea progresses or worsens when lying down, when walking, is there any factor which gives that dyspnea in a particular situation, is there any seasonal variation, does patient experience a wheeze, or is the wheeze audible so that the patient's relative can also sense that patient is having breathlessness. This is seen in asthma and obstructive airway diseases. Whether the dyspnea or breathlessness is associated with chest pain, or whether the patient has an isolated chest pain only, what is the characteristic of that chest pain, where it is located, is it radiating to some place, back or towards shoulder, and whether it is related to the movement of a rib cage, whether it increases while inhalation, and so on. Whether the patient is having hemoptysis, this we have discussed. So these are the general symptoms which we should ask to every patient coming with suspected respiratory abnormality. Going ahead, we should ask the patient whether he or she has had some history of exposure to certain diseases like tuberculosis, whether there is any family member who is having tuberculosis or has been treated for TB recently, whether he has traveled to some endemic areas where the tuberculosis is very common, whether the patient smokes, what type of smoking he is engaged in, whether it is a cigar, bidi, ganja, or some other element, what is the frequency, what is the quantity, whether he is smoking 20 cigars per day, 20 bidis per day, and for how long, 5 years, 10 years, or since childhood, whether the patient is consuming alcohol, what occupation he is into, whether he is exposed to industrial dusts, chemical or allergens, and whether there is any history of exposure to pollen, peat dander, mold exposure, etc. Going ahead, asking family history and past medical history is also important. We should look into whether the patient had measles or influenza in childhood, which can have a long-term effect on a respiratory physiology. Once this history is obtained, we should move for conducting a general physical examination, and we should start looking at the build and nutritional status of the patient. Whether the patient is having normal health stature, whether he is cachexic, whether his body is lengthened, whether he is obese, overtly whether he is dyspneic, what is the respiratory rate, because if the patient is having tachypnea, we can sense it only from looking at his body language, the movement of his chest. We should feel his pulse and should try to see what the heart rate is, whether he has fever, and what oxygen saturation he or she has. So look for cyanosis, clubbing, tremors, lymphadenopathy or edema. We will go through these symptoms one by one. So this is clubbing. So you all can see that the size and shape of the nail is abnormal. The nail bed is widened, the nails are flat, and they have convex kind of a shape. So how to see whether the patient has clubbing or not? So if there are students, you all can do this examination right now. Try to bring two identical fingers of each arm together and see whether that window appears there or not. You can do it right now. Yes. Are you doing it? All? Jay sir, am I audible?
Yes, sir.
Yes. So if you can see this window there, that means you don't have clubbing. But if you have lost, you don't have this window appearing there, that means you have clubbing. So this clubbing is a sign of a chronic obstructive pulmonary disease, congenital heart diseases where there is a mixture of oxygenated and deoxygenated blood. And so there are different grades of clubbing. So the clubbing which I have shown to you is a grade 5 clubbing. This is advanced clubbing. There are stages of clubbing. You can read this in any book. You will come to know that stage wise the clubbing is defined. So this is stage 5 clubbing. We must see by doing general examination whether the patient has clubbing or not. Then examination of a neck and upper respiratory tract. We should see whether patient has some abnormality with respect to the thyroid gland, whether there is enlargement or nodules that may compress airways. Because any structure surrounding airway, right from the trachea, if gets enlarged, then that may cause compression over the trachea, which may cause tracheal deviation. If the patient has a mediastinal tumor or pneumothorax, because of the mass effect of this abnormality, there can be a deviation of trachea. Then patient can have cervical lymphadenopathy suggestive of a tuberculosis, suggestive of some chronic ear-related infection, chronic sinus-related infection. So this is how the thyroid is palpated. You have to bring your finger down from the mid of your chin, and the first prominent structure which you feel is your thyroid cartilage. So you can do it right now. Bring your finger down from the mid of your chin, come down slowly. First prominent structure which you feel, the projection, that is your top of a thyroid cartilage. If you come down slowly and approach to the place where both the clavicles meet, so there is a notch, right? There is a notch. So this is how the thyroid is palpated. Means you have to stand behind the patient and put your fingers, 3 fingers around the thyroid gland and see whether there is any palpable mass or not. Then next you have to see whether the patient is using his accessory muscles for respiration, because in quiet breathing we don't use our accessory muscles of respiration, and we often see that patient coming with severe respiratory distress. By looking at them only we can judge that patient is having some kind of a dyspnea, and this can be sensed whether the patient is using his accessory muscles of respiration or not. Yes. Then auscultation. Auscultation is the important part, and we will have to be familiar with the surface anatomy of the lungs during examination. So we can divide the chest wall in anterior, posterior, and lateral. So anterior chest provide important clues about lung pathology. So right lung has 3 lobes, upper, middle, and lower, and left lung is divided into 2 lobes, upper and lower. So right lung, the upper lobe extends from clavicle, this area, and is bordered by first intercostal space. This. So this is upper lobe. So if we want to mention our findings that there are crepitations in right upper lobe, so we will be putting our stethoscope over this area. Can you see my cursor moving?
Yes, sir.
Yes. So this is upper lobe, right upper lobe. Then there is a middle lobe. It lies around the fourth rib. This is fourth rib at the mid-clavicular line. This is mid-clavicular line. This is mid-clavicular line and extends to the fifth rib laterally. This area is middle lobe. And the lower lobe lies below the sixth rib in the mid-clavicular line, reaching the eighth rib laterally. This is eighth rib here. So this is lateral area. Left lung, the upper lobe extends from clavicle to the fourth rib. This is clavicle here and this is fourth rib. The lower lobe can be palpated at the sixth rib. This is lower lobe. In the mid-clavicular line, this is mid-clavicular line, means the line which joins the nipple from the clavicle is mid-clavicular line. And the eighth rib laterally. So this is eighth rib. So this is anterior chest wall. Posterior chest wall. So more than anterior, we use the posterior surface for the purpose of auscultation, percussion, tapping. All kind of respiratory examinations are done using posterior wall more than anterior wall. So posterior chest wall helps us assess the lower lobes as they are more accessible from this view. The right lower lobe, this is right side, extends from 10th vertebra to 12th thoracic vertebra. The left lower lobe also extends from 10th to 12th, but may show slight asymmetrical pattern due to the position of heart because the heart is situated on the left. This is lateral chest wall. The right lung here. Middle lobe is best assessed from the anterior axillary line to the fifth intercostal space. So you must be knowing how to draw the line from anterior axillary area, from the mid-clavicular area, and using this knowledge of surface anatomy, we can judge which part of lung has abnormality or pathology. Yes. So how to position a patient while performing a clinical examination so as to assess the respiratory function. So proper patient positioning is essential to ensure a thorough and comfortable clinical examination, because we have to make the patient in a suitable position. We have to give the patient a position where he will also feel comfortable. So most of the time we have to undress the patient, we have to remove his clothing, and we have to place the patient in a comfortable position. So if the patient is conscious oriented, is not having overt respiratory distress, so this is the preferred position for performing respiratory examination. So this is a position which can be given to a patient if he is non-acutely ill. So the patient can sit on the edge of a bed or a chair, so that a physician or clinician can also perform comfortable examination. So this position allows observation of the chest wall and help assess patient's overall respiratory effort. Lying back position. If the patient is not comfortable, we can help him lie down, provided that he is given a support. His head is kept at a 45-degree angle. This semi-reclined position helps the patient relax and allows the clinician to observe the anterior chest and perform palpation and percussion with ease. So if the patient is lying down, it is difficult to assess the posterior chest wall. And if we want to do this, we will have to ask the patient to sit for a while so that we can auscultate or do a percussion or palpation on posterior wall also. In emergency situation where the patient is so breathless that he is not comfortable sitting, he is not comfortable lying down, The moment we ask him to lie down, his dyspnea increases or his breathlessness worsens. In that situation, patient only chooses a position in which he try to or struggles to find a comfort, because he is so breathless and he's thriving to take oxygen, means he's struggling to take oxygen in. So in this situation, the patient adopts a particular position where he sits, holding his hand over his knee or holding a stool or bed where he's sitting. This is called as a tripod position, and this is a position patient adopts. I hope you all can see this picture. You can see that the patient is holding a bench or a stool where he's sitting. Plus, you can see that his lips are bluish in nature, means he has a cyanosis. There is a drooling of saliva. This is not a saliva in particular, these are respiratory secretions. This patient must be having a severe episode of exacerbation of COPD or congestive cardiac failure or pulmonary edema, where he is struggling to take or breathe the air in. So he is not able to speak. If you ask him his name, he will not be able to utter it. Even if he speak a sentence, he will speak it in parts. He is so breathless, right? Plus, you can see that he has retracted this epigastric area or ribs, and he has a stridor. He is breathing with the loud voice, which can be audible even from distance also. This is a tripod position, and whenever we see this kind of a patient breathing with difficulty, we must know that this patient is having severe respiratory distress. This is called as a tripod position. So what is a respiratory distress? It is a clinical condition characterized by difficulty in breathing or a sensation of discomfort associated with inadequate oxygenation or ventilation. So increase in the respiratory rate is a cardinal sign of a respiratory distress. So the rate of breathing increases. Normal respiratory rate is between 12 to 20. If it goes beyond this with visible discomfort to the patient associated with hypoxia, if you put a pulse oximeter over the nails or fingers of the patient, you will see that his oxygen saturation is too low. 70%, 72%, 80. Anything below 80% will cause significant respiratory distress in a patient. So how to judge that the patient is in respiratory distress? They will be using accessory muscles. And which are accessory muscles? Recti, rectus abdominis. We use abdomen for breathing, but that is effortless. So if a patient is putting effort in breathing the air in and in exhaling the air out, and if he finds using accessory muscles like abdominal recti, sternocleidomastoid, scalene, and intercostal muscles, and the movement of these muscles is visibly clear to a clinician, it is for sure that this patient is having a respiratory distress which is severe. So these are the accessory muscles which the patient used for breathing when he or she is having respiratory distress. Apart from these, patient can have nasal flaring also. Nasal flaring is widening of the nostrils during inhalation, because the patient wants much more air to come in the lungs. So his tidal volume, which will be much more. Normally we have a tidal volume of 500 or 600 ml. But during respiratory distress, patient may use his inspiratory reserve, right? So at times patient may inhale over a liter or 2 liters of an air, and this much of air, when it enters with force, there is a dilatation or widening of a nasal this nostrils, which we call as a nasal flaring, and this is more often seen in patients who are of a pediatric age group. So when they have a severe respiratory distress, the nasal flaring is most evident. Cyanosis, we have discussed that this is a bluish discoloration of the skin, lips, or mucous membrane due to insufficient oxygen in the bloodstream. So there are two types of cyanosis, peripheral and central. If there is a peripheral circulatory failure, poor circulation, there will be a peripheral cyanosis. Central cyanosis will be apparent when there is a systemic oxygen deprivation. This is more common in patients with congenital heart diseases. So this is how the cyanosis looks. So you must be able to appreciate that the tips are relatively dark in color. Rest of the hand is relatively red, but these tips, means both anteriorly and posteriorly, they have certain kind of a bluish tinge. And this is cyanosis. So this can be peripheral and central both. So if we keep these fingers in warm water, and if cyanosis disappears, this means that this is peripheral cyanosis, because exposure to the warm or something which is hot will increase the blood flow, and the cyanosis may disappear temporarily. So if this happens, then this is a peripheral cyanosis. But even after exposing to heat, this does not disappear, then this means that this is a central cyanosis. And cyanosis will occur only if the patient has desaturated hemoglobin or deoxygenated hemoglobin more than 5 gram per cent. So in severely anemic patient whose baseline hemoglobin is 4 gram per cent, you will never see the cyanosis. Are you getting me? So if somebody is having hemoglobin of 4 gram per cent, and if he is deprived of oxygen, a cyanosis will never appear in him, because so as to cyanosis to appear or visible, the deoxygenated or desaturated hemoglobin must be more than 5 gram per cent. Then there is grunting. This grunting is a sound made during exhalation, and this is common in infants who have significant respiratory distress. Then there is another feature which we can call as a pursed lip breathing. This is seen in COPD patients, chronic obstructive pulmonary disease, because the patients attempt to prolong expiration and reduce trapped air. COPD, there is trapping of air inside the alveoli because the lungs of that patient becomes emphysematous. So patient experiences difficulty in exhaling more than inhaling the air. So these type of patients have pursed lip breathing. They will be using their lips to push their lungs air out because they want to get rid of that tapped air. So in COPD patients, the expiration is prolonged. Then look whether the patient is sweating and is having tachycardia. See the pulse or attach a monitor. Even a pulse oximeter can give you an idea what the pulse rate is. Then these are some of the causes of respiratory distress: COPD, asthma, bronchitis, pneumonia, pulmonary fibrosis, heart failure, pulmonary edema, rib fractures or pneumothorax, hypercapnia or hypoxemia. I don't know whether all students understood these terms or not. If you are studying in first year or second year, you may not have gone through this terminology, but let it be for the time being. We will have more classes on this if you want. So we studied respiratory distress. Now we will see what respiratory failure is. So respiratory failure is an advanced condition of a distress. If distress is not treated, patient will land up into respiratory failure. As there is a cardiac failure or heart failure, there is a respiratory failure also, and this is life-threatening condition. Because in this situation, the respiratory system is not able to perform its physiological functions. What are physiological functions? To provide oxygen to the blood and to remove CO2 from the blood. So if the oxygen is not inhaled, patient will develop hypoxia. So this is type 1 respiratory failure. If the patient is not able to exhale CO2 in the required amount, there will be retention of CO2 and the level of carbon dioxide in the blood will rise. This is called as hypercapnia, and this is a type 2 respiratory failure. So how many types are there? There are two types, type 1 and type 2. Type 1 is hypoxemic respiratory failure, where enough oxygen is not there in the blood. Type 2 is more than CO2 is present in the blood. So whatever CO2 should be there, if that quantity of CO2 rises, then that is called as a hypercapnia. So there are two types. So how this is judged, or this is objectively diagnosed? This is diagnosed using arterial blood gas analysis. So patient's arterial blood is taken and it is checked to see what partial pressure of oxygen is there. If it is less than 60 mmHg, then it is a type 1 respiratory failure. Type 2 respiratory failure, the partial pressure of oxygen may be low or normal, but there will be high pressure of carbon dioxide, high partial pressure of carbon dioxide. So it would be greater than 50 mmHg. So if this is there in ABG, means arterial blood gas analysis, the patient is labeled having type 2 respiratory failure. So this is how the patient's vital signs are to be assessed. The rate, normal rate is 12 to 20 breaths per minute. So if the patient is having respirated more than 25, it is distress. The patient is having respiratory distress. If the rate is low, it is also possible that the patient may have bradypnea. So if the patient has prolonged respiratory distress or respiratory failure, after some time he will develop fatigue, respiratory fatigue, and his respiratory rate will go down, right? In case of CNS depression or drug overdose, like consumption of opioids in any form, will also lower the respiratory rate, which we call as a bradypnea. So what is a harm? If the patient is having low respiratory, he will not be able to inhale oxygen. That will also cause hypoxia. So if we want to count the respiratory rate, we should count it for full 60 seconds. So the method which we use for counting a pulse, like we see the pulse for 15 seconds and multiply it by 4, this does not work well with respiration, because the pattern may vary even within a minute also, in 1 minute also. So it is the best practice to count the respiration for full 60 seconds or 1 minute. So if we apply a pulse oximeter to a patient, we must ensure that his oxygen saturation is over 95%. So anything above 95% is acceptable. If it is below 90, then the patient is having hypoxemia. But while assessing this, we must ensure that the patient is not having cold extremities, he is not in peripheral circulatory failure. Like in cases of a shock, the SpO2 which we sense may be wrong. So this is seen in a patient who is having any kind of situation where there is a poor perfusion. If the patient is having nail polish applied over her or his nails, then also the pulse oximeter may not sense the SpO2 properly. In patients with COPD, if the SpO2 is 90%, we should be happy. We should not ensure, or we should not make effort to raise his SpO2 beyond 92%, because this patient's respiratory drive is based on the carbon dioxide. So if we give him excess CO2, then this patient's respiratory drive will be suppressed and this patient can be in problem. So COPD, the SpO2, targeted SpO2 is 88 to 92%. So capnography, this is method which is used in ICUs, where a tube is placed in the lungs of a patient and the exhaled CO2 is monitored via a particular waveform which gives a numeric value. So this is used in the settings where advanced facilities are available, like ICU, anesthesiologist, or a surgical setting. And the normal EtCO2 means the partial pressure of carbon dioxide which is exhaled through endotracheal tube is 35 to 45 mmHg. So there are some audible respiratory sounds also, which can be heard even without using stethoscope. And the stridor comes at the top of this, which is high-pitched inspiratory sound, which is a sign of upper respiratory or upper airway obstruction, which is more common in children. We should check the patient whether he is anxious, confused, restless, whether he is lethargic. Yes, this can be seen in patients having hypercapnia or worsening distress, as I told you. The patient who has had a severe respiratory distress develops fatigue after some time, and he becomes calm. This is not a good sign. This is a bad sign, right? Positioning, whether the patient prefers to sit, whether patient is okay with lying down, whether the patient is adopting a tripod position. So this is a one short analysis, and if you are experienced within a 10-second, you can judge whether the patient is serious or relatively stable. I'll skip this slide. Yes. So appearance wise, if this type of a patient comes in front of you with a history of severe breathlessness, what your first impression will be? What kind of this patient has? Any answers, audiences, students? Anybody who knows can unmute and answer. What kind of body build-up this is? Is this a normal, obese, or cachexic? Yes. Am I audible?
Yes, sir.
Yes. So this is a cachexia. Karsha. This is a krusha, purush, where there is a muscle loss, there is a fat loss. You can see the indrawing of this area. Means this patient is using accessory muscles also, right? Right. So this patient is of a COPD, chronic obstructive pulmonary disease. So a patient with COPD having history of smoking over 20 years, right? Usually these patients, most of these patients are lean thin. Lean thin. You will hardly find any patient having COPD and obesity together. So prima facie, first impression gives us a diagnosis that this is a COPD. This is how the trachea is palpated. As I told you, put your two fingers within the notch where two clavicle meets. You can do it right now and try to press those two fingers against your trachea. You can see that there are two ridges which you can feel, right? Two cartilages, and you can feel that there is a symmetry. So if there is a loss of symmetry, if you can palpate a notch more at one side than other, it means that there is a deviated trachea. The trachea has shifted to some other side, one side, right? Like this in this picture, this is a trachea coming down. You can see this, right? So this patient must have some mass, mediastinal tumor or something, which has caused this deviation of trachea towards right. Now we are gradually starting. Jay sir, I have time now, 1 hour and more than 1 hour, like that.
Yes, sir.
Yes, yes. So this is a position which we will be using to assess the movement of overall chest or a rib cage. So what examiner or clinician has done, he has kept both his arm, putting the thumb of both his finger over vertebral column, ensuring that he has extended both his arm in a similar fashion over both sides of a chest. And then he will ask the patient to inhale. So what is expected in normal breathing? Both the hands should move equally, because as the patient inhale, his thumb will go apart, right? And he will experience that he is feeling the same type of movement with his both arm when the chest is expanding. Understood? If there is underlying pathology, like If the patient has pleural effusion on left side, then the air is not entering into this area. So this thumb will not move, or this arm or this hand or palm will not move as this palm has moved. The same situation can be there with the patient as a consolidation. So anything which is not allowing that air to enter inside the lung, that area will not move. So before going for X-ray or some investigations, we can primarily diagnose what kind of pathology the patient is having. So this is one. Then we will see the cyanosis in detail. So cyanosis is a sign of hypoxia. Look at lips, tongue, mucosa, nail beds. It may not be visible in anemic or dark skin patient, as I have just told you that we have to have at least 5 gram of hemoglobin to be present in patient so that the cyanosis becomes visible. Then palpation. Palpation is a tactile purposes. This is not palpation. Huh? This is just we are seeing the movement of a chest. This palpation means we are trying to listen the sound using our palms, right? Because when we speak, our words travel outside, but at the same time that sound wave travel inside also. So that vibrations can be felt on chest wall when patient speaks. So you can do it yourself, means you can place your palm over the chest of your friend or a partner or a family member and ask him or her to speak some words like 99. You will feel that particular vibration beneath your palm, right? So you have to place the hands like this only, and initially you ask the patient to inhale so that the chest expands. Now what you will ask the patient to do, you'll ask the patient to utter some word, maybe 99 or blue balloon, like this. When the patient utter a word or a sentence, then that sound wave travels downwards also, and those sound waves appear in the lungs also. So if there is underlying pathology, your feeling or experience of those sound waves generated will differ, right? So if there is air, you will feel different vibration. If there is a water, you will feel different vibration. And if there is a solid substance lying under your palm, you will feel different kind of vibration. Like if we tap a pot which is empty, the sound produces different. The same pot, if there is a water and we tap it, the sound produces different. And if there is some solid which is filled inside that pot, and if we again tap it, the sound produces different. So this kind of sounds are heard and can be experienced or pursued when we keep our palms over the chest of a patient, right? So this is called as a tactile parameters. So when the parameters means this vibration increases, then the patient is having certain kind of pathology. When there is a reduction of this sound wave perception, then patient is having another kind of pathology. So increased parameters is seen in cases where the consolidation or pneumonia is there. The parameters decreases if the patient is having pleural effusion, pneumothorax, or airway obstruction. So this is how the tactile parameters is examined or done. So put your palms of both hands over a chest of patient and ask him to utter some word, and see whether you feel same kind of vibrations under your both palms. So this can be done while placing the flat aspect of your palm. So if you are more experienced and want to locate the pathology exactly, you can use the edge of your hands also. Clear? Yes, I'll move ahead. Percussion. Let me see how this is done. Yes. So if you put your finger of one hand over the table and tap with middle finger of other hand over your finger which is placed on table, you will feel that certain sound is produced. As you move your finger over the edge of table, the quality of sound produced will change. The same thing happens when we tap on a chest of a patient where underlying structure is filled with air, the sound will be different. If it is not air, if it is something which is filled of a fluid like effusion, the sound will be different. And if it is filled with some kind of a solid material like consolidation, fibrosis, the sound will be different. So this percussion also is used as uh, examination, crucial examination to judge or to diagnose the respiratory pathologies. So normal percussion is resonant, right? If we experience or feel that the sound produced by tapping the chest is resonant in nature, it is normal. If it is hyper resonant, it means that the patient is having emphysema or pneumothorax. So if there is more air, like in cases of emphysema, because the emphysema, the air is trapped within the alveoli have become large because they fuse among each other. So the air cannot be expelled easily. So the patients with COPD struggles during expiration, and if we tap on their chest, then the sound which we will perceive while tapping will be hyper resonant. So this is seen in cases of a pneumothorax also. If the patient is having consolidation or pleural effusion, the percussion note will be dull. So the proper word used for this sound is a note, right? And if we tap on a bone or massive effusion, the note will be flat. So basically there are four types of note: resonant, hyper resonant, dull, and flat. So this is how a percussion is performed. Then we will come on to the last part of the examination, which is auscultation, where we all use one particular equipment which we purchase after getting admitted to the first year of BMS. And what is that? What is that? Stethoscope.
Stethoscope.
Yes. And we feel proud wearing it, right? Stethoscope. So it is a symbol that we are a doctor. So normal breath sounds are vesicular in nature. Now listen this part carefully, because even though we have discussed these examinations, but nowadays very less clinicians are seen performing this. But this must be a essential part of our examination, right? So no doubt that we have the support of investigations so as to reach to the diagnosis. But as a clinician, we must be able to exercise all these diagnostic methods before asking the patient to undergo investigation. Because if we are able to derive certain diagnosis beforehand in our mind, and if that diagnosis support is supported by the investigation, then there is a more joy to it. So we can experience, or we can say that my suspicion was correct, my diagnosis was correct, which is proved after the investigation. So normal breath sounds are vesicular. What is the nature of vesicular breath sounds? They are soft and they are heard over most lung fields. So when I use the word lung fields, that means that there are two lung fields, central and peripheral. So the quality of sound will differ. If we put our stethoscope, bell of the stethoscope, diaphragm of the stethoscope over central part, over trachea, the sound will be different. And as we go away from the center, means towards periphery to peripheral parts of the lungs where alveoli are situated. If we put our stetho over sternum, then we are mostly hearing the sound from trachea or main bronchus or some bronchi. But as air moves into the alveoli, its speed decreases. The area available for movement of air is more. So the quality of sound changes. So as I told you that you can listen to the flow of same air, which can be loud when the stethoscope is kept over the sternum, right, or over trachea. So this kind of a sound which is having loudness in it, or which is having high pitch, is sometimes called as a bronchial breath sound. And vesicular breath sound is a soft, which is heard over most of the lung fields. So vesicular breath sound have soft, low pitched and rustling in quality. They originate from air flowing through smaller airways and lung tissue with mostly laminar flow. What do you mean by laminar flow? A flow which has no obstruction, right? If the air is moving smoothly, even though the area or the pipeline is curved, but there is no obstruction. The obstruction is provided by mucus plug, by fibrosis, right? By atherosclerosis, by thickening of the alveoli or respiratory ducts. So if there is no obstruction, the flow of air is smooth, and this is called as a laminar flow or laminar air flow. So when the flow is laminar, the sound produced is a vesicular sound. In vesicular breathing, the inspiration lasts long and is louder than expiration. So inspiration will be more louder than expiration, and there will be no pause in between. So we are talking about normal breathing, right? And these sounds are heard over most of the lung areas and indicate normal lung function. But so as to ensure that the patient has vesicular breathing all over, what you'll have to do, you'll have to keep your stethoscope over all lobes of lung. Right upper lobe, right middle lobe, right lower lobe, left upper lobe, left lower lobe, laterally, anteriorly and posteriorly. So at least 9, 10, 12 places you'll have to put your stethoscope, asking every time patient to inhale and exhale, so as to ensure that patient is having vesicular breathing. Now, I request you to use earphones if you have, because I'll now playing the sounds for you. So listen carefully. This is vesicular breathing. Huh? If sound is not there, please let me know. I'll play it once again. Now see that there is no pause. There is no obstruction, right? The sound is soft, low pitched and continuous. Plus inspiration is more louder than expiration. Listen once again. This is normal breathing, which we call as a vesicular breathing, right?
Please play once more.
Yes, yes, sir.
Please
Once
play
more.
one more.
Yes. Inspiration and expiration. So bronchovascular breathing. First is a vesicular. Now bronchovascular. Now this was low pitched. This is medium pitched, right? And this was soft, and this will have a tubular quality. Tubular means it will appear as if there is passing through some narrow narrow tube. So that will increase its pitch, because the same amount of air is passing. So airflow in bronchovesicular breathing will be more turbulent, right, in larger airways than vesicular, but less harsh than bronchial sounds. Means after this we will see third kind of sound, which is called the bronchial sound. What is the first? Vesicular. Second is bronchovesicular, and after this we will see bronchial breath sound. So bronchovesicular is a mixture of a bronchial and vesicular. So airflow is more turbulent in larger airways than vesicular, but less harsh than bronchial sounds. Bronchial sound we'll be listening after this slide. Inspiratory and expiratory phases are about equal in length. Initially, what was the case? The inspiration was prolonged and expiration was shorter. Here, the inspiration and expiration are about equal in length and loudness. Earlier, the inspiration was loud, expiration was not that loud. So this is difference. So if you are listening a respiratory sound which is relatively loud, where expiration and inspiration are equal in length and loudness, then you are probably listening to a sound which is called as a bronchovesicular sound or bronchovesicular breathing. So this can be seen in cases where there is a consolidation. Consolidation means pneumonia, partial airway obstruction or lung fibrosis. So you can listen to this sound also. Right, now I'll compare this with this normal sound. This is vesicular breathing and this is bronchovesicular breathing. Right? Should I move ahead? Okay. Bronchial breath sounds. So these sounds are even more louder than previous two sounds. Their characteristic is harsh and their pitch is high. So we are now moving towards abnormal breath sounds. So bronchial breath sounds, they typically occur over trachea and manubrium, means below sternum, or inspiratory phase is shorter than expiratory phase. Now, in normal breathing, what was the case? The inspiration was prolonged. In bronchovesicular breathing, what was the case? Inspiration and expiration were equal. Now, what is the case here? Inspiration is shorter and expiration is prolonged. Right? There is a distinct pause. Bronchovesicular breathing was not having pause. There is a distinct pause between inspiration and expiration. And the bronchovesicular sound was moving through a tube. This is moving through a hollow kind of thing. So this is more tubular in quality. This sounds more tubular than bronchovesicular sound, right? So if you hear this over peripheral lung field, this indicate a lung pathology for sure. So if these kind of sounds are heard, then the patient is probably having pneumonia, pulmonary fibrosis, atelectasis, pleural effusion, or anything among these. So I'll playing this sound also. Yes, I'll play it once again. You see that there is a pause between inspiration, even though it is minimal, but it is appreciable. You can sense that there is a pause. You can sense that the inspiration is prolonged. You can sense that there is an amphoric kind of addition to this breath sound. So there are three types of sounds: tubular, cavernous, and amphoric. So this probably is an amphoric kind of a bronchial breathing. Listen carefully. Yeah? I have a quiz for you at the end of this session on these breath sounds only. Then we are moving ahead with another sound which is really important to know, and this type of sound is called as a rails or crackles. So there are two types of crackles, fine and coarse. Fine means minimal, coarse means much crackles. So these sounds are discontinuous. The sounds which we heard, all three earlier sounds were continuous, even though there was a pause in between, but their nature was continuous. There was a continuous flow which was uninterrupted. But when we hear crackles in a patient, the sound which we hear is discontinuous, the pitch is low, moist. The sound itself gives us that there is something moist underneath. There is something which is bubbling sort of a nature of a rattling sound. So this is produced when the air passes through medium where there is a presence of a fluid, mucus or pus. So anything among these, either fluid, mucus or pus is present, and if air is passing through that media, then it will produce a sound which will be having all these characteristics: bubbling, low pitch and discontinuous. So this is typically heard during inspiration, but may also be present in expiration. But crackles are mostly heard during inspiration. And this appears as if somebody is pouring water from a bottle or ripping a velcro. So this indicates airway diseases such as bronchiectasis, chronic bronchitis, or pulmonary edema. In heart failure patients, when the patient is having advanced stage of cardiac failure, decompensated cardiac failure, when pulmonary edema develops, then that time we can listen to these sounds. A presence of crackles in lung indicates that the patient has serious underlying pulmonary or cardiac pathology, right? So if we ask the patient to cough vigorously, so for the time being, you may feel that the crackles have diminished, right? So these are coarse crepitations or coarse crackles or rails. Now listen to this sound. Yes, I'll play it once again. So if you are new, you may feel that all the sounds are same, but all sounds are not same, definitely not same. As you become experienced, as you become skilled, you'll be able to differentiate in each of these sounds. So you can see that there is a definitely discontinuity. The sound is not continuous. It is getting obstructed. It moves ahead forward through the respiratory passageway. It is getting obstructed by various kind of obstructing agent. So its pitch diminishes. It produces a sound of bubbles. So this is a coarse crackles or rails. Now we will see what fine crackles are. Fine crackles are a mini form of coarse crackles. Coarse means severe. Fine means minimal. So these are short, but these are having high pitch because the obstruction is not as severe as it was with a pathology which was responsible for producing coarse crackles. This is soft, popping lung sound produced by sudden opening of small airways. As air passes into the small airway, those airway gets opened with the pressure, or those alveoli which are collapsed get open as air passes. And this happens typically in alveoli which are having a collapsed state because of the presence of fluid or lack of air. So as the air passes into this alveoli, that air produces certain sound which we call as a fine crackles. So this is usually heard during late inspiratory phase. End inspiratory crackles, this is called as. So we have to ask the patient to take a deep breath, and we have to put our stethoscope throughout inspiratory phase to see whether we are able to listen these crackles at the end of inspiration, right? So if the patient is having crackles only at the end of inspiration, then these are mostly fine crackles. Understood? So this is seen in early stages of heart failure, atelectasis, pneumonia, or pulmonary fibrosis. So you can listen to this sound also. So I compare this with coarse crackles. So here the sound is throughout the cycle, inspiration and expiration with a pause in between. Here you can see that there is a gap. The sound is heard at the end of inspiration only, and first two parts of inspiration are quiet. So why this sound is heard at the end of inspiration? Because it is a phase when the air enters into the small alveoli, small airways. That is at the end of inspiration, when it attempts to open the collapsed alveoli and pass through alveoli which are filled with fluid. So that time these type of sounds are produced, which we call as a fine crackles. Then wheeze. Wheeze is a high-pitched musical continuous lung sound. So you should remember each of these words or terms. High-pitched musical continuous lung sound produced when air flows through narrowed or compressed airway, causing airway walls to vibrate. Means the air is passing through airway with a force so that it produces a kind of vibrations over those walls of airways, and this produces a high pitched sound which even can be listened by standing beside the patient. So it is not always required to put a stethoscope so as to listen the pitch, right? Or audible bronchi sort of thing. This is wheeze, and these are two types: monophonic and polyphonic, right? So listen to this monophonic wheeze. So when there is airway obstruction, bronchoconstriction, or if there is some plug which is stuck in the airway, if there is a bronchial edema in cases of a bronchitis, then at that time this monophonic wheeze is produced. Polyphonic wheeze is more harsh than this. Yes. So can you tell me whether you are able to listen this during inspiration or expiration? I'll play it once again. So wheezes or wheeze is mostly audible during expiration. But this is more common in cases of a COPD, bronchitis, or allergic reaction. Wherever there is a bronchospasm, or when there is a limitation to the airflow in the bronchus, then that time the wheeze is produced or wheeze is audible. Then bronchi. There are so many lung sounds. Listen. Yes, so there are now, can you compare between these and these? The pitch is more. In wheeze, the pitch is more. This is more prominent during expiration. The bronchi, the pitch is low. This is continuous. Right? So bronchi are produced when there is obstruction in the large airways, bronchus or subsequent branches of bronchus, this bronchi. Yes, so if you listen these sounds carefully in hundreds of patients, then only you'll be able to judge whether this particular sound is a bronchi or wheeze or crackles or like anything. And then this is probably last but one, stridor. So stridor is a high-pitched, continuous musical breathing sound caused by turbulent airflow through a narrowed upper airway. Now, the sounds which we played previously were not limiting to any particular area, means not limiting to upper airway for that matter. This sound is limited to the production of turbulent airflow when the air moves through a narrowed upper airway. And this is loudest during inspiration because the patient struggles to allow the air pass through the upper airway down into the lung. So this is heard mostly during inspiratory phase, right? It can be heard during expiratory also, but it is most commonly heard during inspiration. This indicates that the patient has severe, significant upper airway obstruction, which may be because of infection, like whooping cough or epiglottitis, foreign body obstruction, foreign body aspiration, tumors, or vocal cord dysfunction, or trauma to the upper airway, allergic reactions like anaphylaxis or swelling of upper airway. So this stridor indicates a partial obstruction at the level of the upper respiratory tract. So listen to the sound. So if you encounter a child 2-3 years old presenting to you with history of fever like cough, and if you auscultate him and see that stridor is present, that this indicates that there is a severe upper airway obstruction, which is because of epiglottitis or croup or whooping cough. If the child is not having any history of fever or cough, and if he suddenly develops stridor, that indicates that he may have swallowed something which might have caused the obstruction, with the foreign particle must have stuck into his upper airway, and that he is struggling for breathing. So this is serious symptom and we should refer this patient to a specialist. So this is stridor. Then the last sound is a pleural friction rub. So you know that the lungs are surrounded by pleura, visceral and parietal, and there is a fluid in between which helps slide both the pleura over each other. This is also a shock absorber, and this also plays an important role in pulmonary ventilation. So if there is inflammation within the pleura, pleuritis, or if there is any underlying pathology because of infection like pneumonia, tuberculosis, malignancy, embolism, at that time this pleura rubs over each other and they produce certain sound which we call as a pleural friction rub. So this sound is harsh in nature. This appears like creaking sound which is heard during inspiration, and this is like as if somebody is walking on the ice wearing shoes and pushing ice through his shoes as he walks. So listen to this sound. So this is pleural friction rub. So obviously you will have to put your stethoscope over the area where pleura are situated, means lower part of the lung. And if you feel that during expiration there is this kind of sound and patient is complaining of a pain over the shoulder or pain during expiration, as he inhales, this pleura rubs with each other and that produces sound, and patient will experience the pain also. So these patients have fear of inhaling much air into the lung. So if this sound is there, this is pleural friction rub. So I'll play this once again for you. Yes. So this is pleural friction rub. So you can read this slide, and I have a quiz for you. I'll be asking you to guess all the sounds now. Just go through this for I'll keep this slide here for a few seconds. Right now, guess the sound, huh? So you can use the chat box. Miss, I don't know how to see the chat box. Just a moment. Let it be. You all can open your mics. You can unmute yourself and answer the questions. So guess the sound. Start. What was this sound? Any guesses?
Hello.
Yes.
Can you please raise up the volume of the sounds? They are not very clear. I mean, not.
Okay. Okay.
They're
Okay.
very
Just a moment.
slow and very
Just
even
a
on
moment.
earphones.
Yes, ma'am.
that vesicular sound?
No. This is not a
No,
normal
it's a
sound.
sorry, sir, bronchovascular sound.
No. This is bronchial breath sound. This is amphoric in nature, no? Loud in pitch, right? So, yes, just so once again, Jay sir, we have 10 minutes more.
Almost finished, but you can extend 5 minutes more, sir.
Okay, no problem. Yes. So this is vesicular sound. Please. Right? This is vesicular sound.
Okay.
Yes, and this is bronchial breath sound. The pitch is loud, harsh. Right? As if it is passing through some hollow place. So this is bronchial breath sound. Yes, so we will. This is bronchial breath sound. Yes. Now second sound. This is bronchial breath sound only. And now second sound. Listen carefully.
Crackle sound.
Yes, this is coarse crackles. Like coarse. We had studied two types of crackles, no? Fine and coarse.
Yes, sir.
Yes, those are coarse crackles.
Okay.
Now third. Come on. Again crackles. Inspiratory crackles. Fine crackles. The earlier previous was coarse crackle. Now what is this? This I had not played, huh? This is diminished sound, diminished breath sound. Patient is not having full breath. Now, what is this?
Wheezing.
Wheezing. This is expiratory.
Wheezing.
Right.
This is
Wheezing sound.
classical wheeze.
This
Yes.
is wheezing, yeah.
Wheezing.
Very typical wheezing.
Mm-hmm. Now, this is last sound which you could play.
Stridor.
No. Plural rub.
Okay. Yes.
Plural rub. Now, same sound in expiration and inspiration. High pitch, loud. What is this?
Straddle.
Ronchi. Now comes this is Strider.
Strider.
Yes, this is Strider. Right? Now guess the last one.
Vascular.
Yes, vesicular breath sound. Who is this? Are you a student or a faculty?
Student, sir, from
Good.
Tarnath.
Good. Yes. So that's all from me, Jay sir. If students have any questions and if the time permits, we can take these questions. But let me tell you that this type of teaching or classes needs a time span of over 1 or 2 weeks. Means it is difficult to give justice to such topics in 1 hour or 1.5 hour.
Good, sir. One question is here.
Yes.
Can you please elaborate on cyanosis sign?
Cyanosis. So cyanosis is bluish appearance of skin, nail beds, and conjunctiva or tongue. So cyanosis means deoxygenated hemoglobin. Like when hemoglobin is associated with oxygen, we call it as a oxyhemoglobin, right? When it becomes devoid of oxygen, we call it deoxygenated hemoglobin. So the level of deoxygenated hemoglobin, if it rises above 5 gram, means the circulating hemoglobin which is not associated with oxygen is more than 5 gram per cent or per deciliter, then cyanosis becomes apparent, right? So this can happen if the patient is not breathing enough oxygen, or if the oxygen is circulating but is not getting delivered to the tissues. So in both situations, the cyanosis can appear. If the patient is in shock and there is a peripheral circulatory failure because of a severe vasoconstriction, because what happens in shock, the body tries to reserve the blood flow so as to ensure that it is supplied to the vital organs only, brain, heart, and kidneys, and periphery is kept devoid of blood supply. So in that situation, the patient appears cyanosed. Is this clear, sir? Hello.
Sir, one more question. Sorry.
Yes.
Can you please differentiate the two types of wheezing again?
Wheezing.
Yes. The course one and the fire.
Yes, monophonic and polyphonic, right? So if the airway involved are less in number, right, means if the obstruction is relatively less, the wheeze produced will be relatively lesser or of a lesser intensity, and there will be only one kind of a wheeze audible in that. You listen to this. Now listen to this. Polyphonic. Right? So when the air moves through a large airway, right, one large airway, so that the obstruction produced is relatively less. So monophonic wheeze is a single continuous and high pitched note, while polyphonic is continuous high pitched musical note with varied harmonics. Means you can see that there are multiple components involved in polyphonic wheeze. So to simplify this, if the obstruction is because of the large airway, bronchus and some bronchi, then the wheeze produced will be monophonic. If the obstruction is extended, if it is in the smaller airways also, periphery also, then the wheeze produced will be polyphonic. So if it has more variety included in it, more variety of sound or wheezes, then it is polyphonic. If the variety is only one, the character of wheeze is only one, then it is monophonic. Anything else?
I think completed the question. Now it's really it's a very knowledgeable session. Now it's time to move forward. अभी समय हो गया है कि समापन इस सत्र का समापन किया जाए। तो समापन के लिए मैं वैद्य संतोष जी गटने को बुलाना चाहता हूँ। संतोष जी जो हमारे आरोग्य भारती पश्चिम प्रांत के सचिव है, सर को मैं इनवाइट करना चाहता हूँ। सर प्लीज।
So just Ade sir, would you please give me a few minutes? If any students, are there, means I just wanted to ask you, did you understand the topic?
Yes, sir.
Yes, sir.
Good. If I am able to
Yes, sir. Yes.
stimulate interest in you so that you can learn this further, that is what I want to gain from this session. So thank you. Yes, sir. Please go ahead.
संतोष जी।
मला वाटतं तुम्ही करा पुढचं घ्या. Please continue, Jay sir. Next.
Now it's time to for vote of thanks. So
Can I talk? Am I audible?
Yes sir. Yes sir. Please.
Am I audible?
Yes sir. Yes sir. Sir, you are audible. Please.
Thanks, Pardeshi sir, with your very useful knowledge you share. We are very thankful to you. With this knowledge, all the students, practitioners, are prepared to problems. It's dangerous. One of the challenge that was TB in 215 percentage of TB patients in India, it was up to 17.9%, and with our efforts which we have done by the medical fraternity, nowadays it is near about 199 patients against 1 lakh population. But still the respiratory diseases problem is challenging us. The fourth most biggest reason behind death, the cause of death, COPD, and that is the most dangerous problem against us. And we have to face this problem, and we have to solve this problem. To face and solve these problems, we must know how to face the problem. And today, Dr. Pardeshi taught us how to tackle these problems. One of the reason behind the problems of diseases is smoking, and near about 12.8% of the Indian population is under the addiction of smoking, and the passive smokers, number of passive smokers is also much more than 12.8%. So we are facing the problem of addiction also. So we have to take this challenge and face this challenge and solve the problems again of the nation. And with this, by this knowledge, we can face the problem, and by this some words speech. Thanks.
Thank you, sir. Now it's time for the vote of thanks. I would like to thank Arogya Bharati Paschim Maharashtra Prant for giving the permission to conduct this national seminar. I am also thankful to Dr. Murli Krishnan sir and Dr. Santosh ji Gatne sir for having us today's webinar. I sincerely thanks our guest speaker, Dr. Raviraj Pardeshi, who is my mentor, for sparing valuable time and delivering insightful session. Special thanks to all participants and students who join us today. I also acknowledge the efforts of organizing team, technical staff, whose dedication is toward the smooth conduct of this webinar. With that, we conclude today's session by Shanti Mantra. For Shanti Mantra, I would like to invite Chetna, BMS second year student, SJRA Solapur. Chetna, over to you. Chetna, ho aap?
Yes, sir. सर्वे भवन्तु सुखिनः, सर्वे सन्तु निरामया, सर्वे भद्राणि पश्यन्तु, मा कश्चित् दुःखभेत्। ॐ शान्ति शान्ति शान्तिः।
Thank you once again to everyone for your gracious presence. Thank you.
Thank you, Jay sir. The students are asking me to share the PowerPoint presentation. So if it is okay for you, yes, or if it is, the session is recorded on YouTube and the link can be shared, it will be good.
Definitely.
And yes, I'll be